आपका सही आ रहा है?
हाँ, हमारे पास सही है।
Okay, students, learning objective of today's lecture is to learn about the structured outline of the thorax, what you know about the thoracic cage. You have already learned, you are familiar with the anatomy of the thorax, you have already learned that. So we'll be discussing about the knowledge which you have already have. You will be able to know the components of the thoracic cage, different compartments of the thoracic cavity, what are the boundaries of the cavities, what skeleton is responsible for making this thorax, and what is the mechanism of respiration. So talking about the thorax, thorax is the region which lies between the neck and the abdomen. The region between these two regions is the thoracic region. It has got a skeletal framework, which is also called thoracic cage, because it represents like a cage-like appearance because of the presence of 12 ribs on either side. And the cavity of the thorax contains important structures, vital structures of the body, like heart and the lungs. And the primary function of the thorax is to assist in respiration, but secondary function is also to protect the organs of the thorax particularly, and the upper part of the abdominal organs generally. So important viscera are protected by the thoracic cage. This is the posterior view. The posterior side of the thoracic cage is referred to as the back. It's not part of the thorax. The part of the thorax is anterolateral and anterior region. That is the thorax. And it is separated from the abdomen by a partition which is called diaphragm. Diaphragm is the lower limit of the thorax. It is attached to the margins of the thorax over there. But because of this protrudes inside, upwards into the thorax, that's why the thoracic cavity itself is a very small cavity. And the abdominal cavity is extended into the thorax so that the upper viscera of the abdomen, like liver and the spleen and the upper part of the stomach, they lie under the protection of this rib cage. And the primary function, as I told you before, is the respiration. If you talk about the openings of the thorax, so thoracic cage is just like a cone-like structure which is narrow above and broader below. Sometimes thorax is also is taken as the chest, but chest is the appearance which is broader above and narrower below. If you talk about purely about the thoracic cavity, it is narrow above and broader below. So it has got an inlet and outlet. The inlet is that part of thorax which communicates it with which attaches it with the neck, and the outlet is that with which it is connected to the abdomen. Thoracic inlet is called by the clinicians as the thoracic outlet. This is a special name given to the cavity which is bounded, or the aperture which is bounded by the first rib and the sternum and the first vertebra, which is called by the clinicians as thoracic outlet. So now you are in the clinic, so you would be hearing the thoracic outlet syndrome, for example, but anatomically we call it as thoracic inlet. It is, as you can see, it is placed obliquely. It's not a straight horizontal opening, it is oblique opening, and this obliquity is because of the position of the first thoracic vertebra, which is at a higher level, and the position of the upper part of the sternum mandibular, which is the anterior boundary of the thoracic inlet, that lies at the level of the fourth thoracic vertebra. So this aperture is obliquely placed. It faces forwards and upwards. And it is the passage for different structures which are passing from the neck into the thorax, from the upper limb to the thorax, and vice versa. Some of the structures are entering the thorax, some of the structures are leaving the thorax and entering the neck, and the arm. Below, the thoracic cavity communicates with the abdomen, but it does not directly communicate with the abdomen because it is covered by the diaphragm. This diaphragm is a musculotendinous sheath which separates it from the thoracic cavity from the abdominal cavity, and this is the most important inspiratory muscle, which is also responsible for the maintenance of the intrathoracic pressure as well. And in a normal relaxed state, it lies at a higher level as compared to the lower boundary of the thorax. The structures which pass from the thorax into the abdomen or vice versa, they pass either through the openings into the within the diaphragm, like opening for the inferior vena cava, opening for the three important openings are for the inferior vena cava at T8 level, the esophagus at T10 level, and the aorta, which actually does not penetrate it, but it lies behind that and passes at the level of T12 vertebra. Thoracic region, you can study the thoracic region in two parts. Number one, the wall of the thorax. This wall of the thorax is made up of osteocartilaginous framework, means osteocartilaginous means consisting of the bone as well as the cartilage, because the ribs are connected to the sternum with the help of costal cartilages. So it is called osteocartilaginous framework. On this framework is, or between these ribs, the wall is made by the muscles which are present over there, the intercostal muscles. They complete the walls of the thorax, and posteriorly is the vertebral column, thoracic part of the vertebral column, and anteriorly is the sternum. Next is the thoracic cavity. The thoracic cavity is divided into mainly the mediastinum, which is the middle part, excluding the part which contains the lungs. All the part of the thoracic cavity which is there without lungs, that is called mediastinum. So lungs are present in the pleural cavity, not exactly within the pleural cavity, but they are covered by the pleural cavity, because pleural cavity consists of the visceral and parietal pleura, and which do not have any actual space. They have got a potential space between the parietal and the visceral pleura. So you cannot exactly say that the lungs lie within the pleural cavity. Lungs are covered by the pleural cavity. So on the space which remains on between the medial aspects of the lungs, that is actually called the mediastinum. The thoracic cage, if you talk about the thoracic cage, it is bounded anteriorly, as you can see here. It is bounded anteriorly by the sternum, having the manubrium, the body of the sternum, and the xiphoid process, joined by secondary cartilaginous joints. Secondary cartilaginous joints are slightly movable joints having some fibrocartilage in the center within the cavity. And posteriorly, it is bounded by the vertebral column from T1 to T12. Right? First rib is attached to T1, and the 12th rib is attached to 12th thoracic vertebra. So the lateral boundary of the thorax is formed by the ribs, 12 pairs of ribs on either side. Laterally by the ribs, and the space between the ribs is called intercostal space. That intercostal space, if the vertebrae are 12 in number, the intercostal spaces would be 11 in number. So these intervertebral spaces, intercostal spaces are filled with the intercostal muscles, and the neurovascular bundle also lies over there. Above the opening on either side, above the apices of the lungs which are present here, there are the suprapleural membrane. Suprapleural membrane is present over there. We will be discussing about that in a while. The suprapleural membrane, which is also called Simpson's fascia, that covers its apex, and the space between two suprapleural membranes is occupied by the structures which are entering or leaving the thorax in the central part between the thoracic vertebrae and the sternum, manubrium sterni. So the boundaries of the inlet, if you see the inlet boundary, you will see that this is the upper part of the thoracic vertebra 1. Then laterally it is bounded by the medial margin of the first rib, and then the upper margin of the sternum manubrial, which is called sternal notch here. It's a depression. This is called sternal notch. So this is the boundary of the thoracic inlet. Below it is bounded by the diaphragm. Sternum, you can see here, it consists of three parts: the manubrium, which is here, the body of the sternum, and the Ziphite process. And you see that when I move my arrow, the slide changes because I'm not using mouse. That's it is very sensitive. So you see that the manubrium has got a jugular notch over here. Then there are two facets which are visible here. Upper facet is for the clavicle, and the facet below that is for the costal cartilage of the first rib. Now remember that first rib is joined with the manubrium. The cartilage of the first rib is joined with a joint which is called primary cartilaginous joint, right? It is joined by primary cartilaginous joint. Rest of the cartilages, the costal cartilages, are attached to the sides of the sternum by the synovial. They are joined by the synovial joints, which are movable joints. But the first joint is not movable. And the second rib is joined at the junction of the manubrium and the body of the sternum, and it has got two cavities corresponding to these two bones. If you talk about the ribs which are attached to the sternum, so you can divide these ribs into, or you classify the ribs into the false ribs and the floating ribs. True ribs are those which are directly attached to the sternum. These are the ribs 1st to 7, right? These are the ribs which are called true ribs. They are attached directly to the sternum. Then the ribs below that, that is 8th, 9th, and 10th, they are joined to the costal cartilages of the upper ribs, and they form the costal margin. And those ribs are called false ribs. If you see here, the 1st, 2nd, 3rd, 4th, 5th, 6th, 7th, these are the ribs which are joined directly to the sternum. Then the 8th, 9th, and 10th are joined to the upper ribs, the cartilages of the upper ribs. They are false ribs. And the 11th and 12th ribs, they do not join the sternum neither directly nor indirectly. They do not join with it at all. So they are called floating ribs. They lie within the musculature of the abdominal wall. So typical ribs. Then if you talk about the ribs, then the ribs can be divided into typical ribs and atypical ribs. Typical ribs are those which extend between 3 and 9. 3rd to 9th ribs, they are typical. That is, they have all the features which are in common with each other, right? And the ribs 1 to 10, 11, 12, they are called atypical ribs. Why they are typical and atypical? Now, the typical rib has got certain features which you can see in this diagram. It has got a head which has got facet, and this facet, there are two facets on the head. One facet, the lower facet, is for the articulation with the vertebra of the corresponding number. It will join, or it will make contact with the 7th vertebra at the lower facet. The upper facet would make contact with the vertebra above that level, right? And there will be a ridge in the middle of these, which divides this is a joint, is a synovial joint, and this synovial cavity is divided into two cavities by the presence of ridge between two facets on the medial aspect of a typical rib. Then the head leads to the neck, which joins it to the tubercle of the rib and facet of the rib, transverse facet for the transverse process. You can see that this is the facet for transverse process. And just lateral to that is a tubercle, rough area of the tubercle, which is for the attachment of a ligament, a lateral costotransverse ligament. This is, I am talking about a typical rib. Then the typical rib turns around at angle and passes downwards and forwards, and it becomes flat. And this, it has got an upper margin and lower margin, and below that, on the inner side, is a costal groove. It is a depression, longitudinal depression, which is called costal groove. That is for the protection of the neurovascular bundle, which runs in the intercostal spaces. So these are the parts of the typical rib: head, neck, tubercle, angle, shaft. Shaft is the body of the rib, and subcostal groove. Atypical ribs, if you talk about the first rib, this is the smallest, small rib and a very strong rib. And this rib is different from other ribs that it has got an upper surface and a lower surface, because it is flat horizontally. It lies, it is it lies like this. It does not like this. So it has got an upper surface and lower surface. The upper surface has got a tubercle, which is called a scalene tubercle. It's marked over there. Scalene tubercle is that to which the anterior scalene muscle is attached, scalene anterior is attached. And in front of that runs the subclavian vein, and behind that there is groove for the subclavian artery, right? And it also has got a single facet on the head, because it only articulates with the vertebra of its number, that is first thoracic vertebra. It does not articulate with the seventh cervical or the vertebra above. So that's why it is it is an atypical rib. It is different from all the other ribs. Second rib is close to the typical, but there is a slight difference, that it has got a tuberosity for the serratus anterior over there, and that makes it somewhat different from the typical ribs. Otherwise, the other features are similar to the typical ribs. Similarly, if you talk about the ribs articulations, you can see in this diagram that the head of the rib articulates with the vertebrae, thoracic vertebrae. In a typical rib, like here it is shown the seventh rib, it articulates with the seventh vertebra, upper facet on the body, lateral aspect of the body of the seventh vertebra, and it articulates with the upper facet of the head, articulates with the vertebra above that level, that is T6. So the head articulates with the vertebra of the corresponding number, as well as the vertebra of a number less than that, that is upper vertebra. And the middle aspect joins with the intervertebral disc. So this is how the typical ribs makes a joint over there. And remember that all these joints are synovial joints. Then you see that when it passes backwards and laterally, the tubercle of the rib. Now, tubercle of the rib is articulating with the facet which lies on the anterior aspect of the transverse process, and this forms the first joint which I told you, that is the costovertebral joint, and this second joint which the which the tubercle makes with the transverse process is costotransverse joint. This is also a synovial joint, right? So these are the two joints which are which forms rib articulations posteriorly. Ventrally, the ribs articulate with the as I told you in a previous slide, this is the enlarged view of the joints on the posterior aspect of the ribs, right? Costovertebral and costotransverse joints. And the red line, which is shown over here, that shows you the axis of rotation of the ribs, how the ribs are elevated and depressed. And the very, because there are strong ligaments on the posterior aspects, so the movement is limited on the posterior aspect, but that small movement leads to gross movement on the anterior end of the ribs. Anteriorly, the ribs are joined with the, as I told you before, they are joined with the sternum, with the all the joints are with the costal cartilages make with the sternum. They are synovial joints, except the first rib, which articulates, which has got the primary cartilaginous joint. Now we talk about the thoracic vertebra. Thoracic vertebra is different from other vertebrae. There are very particular features of the thoracic vertebrae which make it different from other vertebrae. The upper and lower, superior and inferior articular facets are similar except for the directions for the movements of the vertebrae. But the most typical feature is the transverse costal facets, which are present to make costotransverse joints. Then there are demifacets on the vertebral bodies. This we are talking about the typical vertebra, right? Demifacets means half facets on the upper and lower ends of the posterior part of the lateral aspect of the vertebrae, close to the pedicels. So these demifacets articulate with the part of the head of the rib. Spinal processes of the thoracic vertebrae are long, directed downwards, and there are superior articular facets which face dorsally, posteriorly, as you can see in the diagram, and inferior articular facets down ventrally or anteriorly. And the vertebral foramen is almost circular, not completely, a heart-shaped body. So these are the most characteristic feature of the thoracic vertebra is the costal facets and demifacets, transverse costal facets and the demifacets. You can easily recognize these vertebrae. Now, if the first rib articulates only with the first thoracic vertebra, it means that first thoracic vertebra would be having only one facet for the head of the first rib. So that would be an atypical vertebra. Here you can see the costal facets and the transverse costal facets, body of the vertebra, shape of the vertebra, everything is visible here. Now, we talk about the intercostal spaces. Intercostal spaces are the spaces between the adjacent ribs. They are bridged by 3 layers of muscles, which correspond to the muscles of the abdomen. There are 3 layers of muscles. So there are the external intercostal, internal intercostal, and innermost intercostal muscles. I'm not going into the detail of these muscles, but these muscles are for the respiration, for the movement of the chest and thoracic wall to cause respiration. And there is neurovascular bundle is present, which consists of the intercostal artery, intercostal vein, intercostal nerve. This neurovascular bundle lies within the intercostal space, and it runs close to the subcostal groove and runs between the inner and the internal and the innermost intercostal muscles. This runs, the neurovascular plane is present between the internal intercostal and innermost intercostal muscles. And the lower part of the intercostal space or the subcostal groove protects these structures to a certain limit. Now, thoracic inlet, we have already talked about the boundaries of the thoracic. Posteriorly, it is bounded by the upper part of the first thoracic vertebra. Then there is lateral boundaries formed by the medial border of the first rib. And anteriorly, it is bounded by the upper margin of the manubrium sterni. Now, in the you can see that there is a suprapleural membrane. You can see here the suprapleural membrane is the substance fascia, which is attached on the inner margins of the first rib. and medially it just becomes continuous with the mediastinal structures over there, the fascia over there, and upper part of this fascia is attached to the transverse process of the seventh cervical vertebra. And this substance fascia is a tough fascia which lies just above the dome of the lungs and prevents the entry of the lungs into the neck, right? If there is a cut in this fascia, there would be emphysema over there, right? That is, the presence of air would be there within the root of the neck. So the central part of the thoracic inlet, which is very narrow part, it becomes further narrowed because of the forward protrusion of the first thoracic vertebra, and this allows different structures to pass through it. The midline structures are the trachea in front, then the esophagus, and on the sides there would be vessels like on the right side you will be seeing the brachiocephalic artery, which divides into the common carotid and the right subclavian arteries. On the left side, the two arteries arise separately from the arch of the aorta, and then they leave the thoracic inlet and go into the towards the arms and towards the neck. And you can also see green-colored thoracic duct, substance fascia, and then enters the systemic circulation, like at the junction of subclavian vein and the internal jugular vein. And the important nerves which pass over here, they are the vagus nerve on the medial aspect and the phrenic nerve on the lateral aspect. Most important thing to be appreciated here is the presence of recurrent laryngeal nerves which run in the gap between the trachea and the esophagus, right? Trachea is in front, esophagus is behind, and between these two are the right and left recurrent laryngeal nerves are present. So these are the important structures which are present within the thoracic inlet, or which leave and enter the thoracic inlet. The lower opening, the diaphragm, that is actually a musculotendinous sheath which is attached to the margins of the thoracic inlet. And this thoracic inlet, as you can see here, this is the costal margin. Below you can see the costal margin, and behind, and the diaphragm is attached to the costal margin and anteriorly to the sternoziphoid junction, and behind up to the level of the 12th thoracic vertebra. But the diaphragm is not lying at the same level in the center. In the center, it protrudes upwards into the thoracic cavity, so that most of the viscera in the abdomen, they lie protected within the thoracic cage, right? And this is called dome of the diaphragm. It is pierced by three large openings. Rather, there are two large openings, one for the inferior vena cava at the level of T8, one for the esophagus, and the aorta passes behind the diaphragm at the level of T12 vertebra. There are other small openings for the passage of other vascular structures and the nervous structures. So the lower boundary of the thorax is the diaphragm, which is a mobile structure, which is inspiratory muscle, which is innervated by the phrenic nerve. Now this is the view of the thorax. Now you know that the main function of the thorax is respiration. So the movements which take place in the thorax, they are, if you remember, there are two types of movements. One is the bucket-handed movement, and one is the pumping movement, right? Anteroposterior and lateral dimensions of the thoracic cavity, they are maintained by these movements. So the inspiration, during inspiration, what happens that during inspiration, the diaphragm contracts. When the diaphragm contracts, it becomes flattened. When it becomes flattened, what happens that the intra-abdominal pressure raises and there is negative pressure in the thoracic cavity. The ribs also elevate. Upper ribs usually elevate laterally, bucket-handed movement, and the lower ribs, upper ribs, they pass laterally as well as anteriorly. They also elevate the sternum. They increase the anteroposterior diameter mainly, but also to some extent the lateral diameter, and the lower ribs, they increase the lateral dimensions of the diaphragm and of the thoracic cavity, and the diaphragm increases the vertical dimension of the cavity. So this produces negative pressure within the thorax. It means the negative pressure in the thorax means it will cause the air to be sucked into the lungs, which are required, which can be required. They expand by the lungs, right, to compensate for negative pressure, and this is called inspiration. When the muscles relax, then what happens that the lungs recoil because of the elasticity, and the air goes out, and this is for the expiration. So inspiration is an active process, expiration is a passive process in a normal tidal respiration. In a forced expiration, other muscles also take into action, are taken into action. So we are not going into detail of this, but if you see the muscles of thorax, you can divide into extrinsic and intrinsic muscles. Extrinsic are the pectoralis major, pectoralis minor, serratus anterior muscles, and intrinsic, as I told you before, they are intercostal muscles, external intercostal, internal intercostal, and innermost intercostal muscles. And in the anterior aspect, on the inside, are the transverse thoracic muscles. This is actually part of the innermost intercostal muscle. So this is also, basically there are three intrinsic muscles, intercostal muscles, and basically these are the muscles which are responsible for inspiration. The cavity of the thorax, as I told you before, that it is divided into a central peritoneal cavity, mediastinum, sorry, not peritoneal, mediastinum, and the pleural cavity on either side. Pleural cavity on either sides, they actually cover the lungs, right? Whatever space is left by the lungs, that is occupied by the mediastinum. So mediastinum is the cavity within the thorax, excluding the cavity which contains the lungs. So it is all, you can see that this is the cavity which is present between the medial aspects of the two lungs. That is called the mediastinum. It extends from the sternum, that is thoracic inlet, to from the thoracic inlet up to the thoracic outlet. However, it is divided for the purpose of studying and further understanding. It is divided into superior mediastinum and inferior mediastinum. First, you can divide it into superior and inferior. The green one in this picture is the superior, and below that is the inferior mediastinum. Superior mediastinum runs from the mandible, this joint, which is the angle of Louis, sternum-mandibular joint, where the second rib is attached. On the side is the second rib is attached over there. If you count ribs, you start counting from this area. So from here, an imaginary horizontal line is drawn which extends up to the lower part of the fourth thoracic vertebra. So the space of the thoracic cavity above that is the superior mediastinum, and below that space is the inferior mediastinum. Inferior mediastinum is further divided by the fibrous middle and posterior mediastinum. The mediastinum which lies anterior to the heart, that is the anterior mediastinum. The part of the mediastinum in which the heart lies, that is within the fibrous pericardium, that is the middle mediastinum, and part which lies behind that, between the thoracic vertebrae and the heart, that is the posterior mediastinum, right? So these are the divisions of the mediastinum. Superior mediastinum from the inlet to the level of the fourth vertebra behind, and the sternal angle or the angle of Louis in front. And the inferior mediastinum divided into anterior and posterior, anterior, middle, and posterior by the presence of heart. Anterior to the heart is the anterior, when the heart lies within the middle mediastinum, and the rest of the space behind the heart between the thoracic between the thoracic vertebrae and the heart, that is the posterior mediastinum. And different structures run over there. We are not going into detail of those structures because the time is limited. So mediastinum, you can say that it's an imaginary plane passing through T4, and it divides it into the superior and inferior mediastinum. That's the imaginary plane which divides it into the superior and inferior mediastinum at the level of T4 vertebra, lower part of the T4 vertebra, and interiorly it is the angle of Louis or the sternum-mandibular joint angle, right? Inferior mediastinum further divided into heart, which is present in the middle mediastinum, and the anterior and posterior mediastinum, which lie in front of and behind the heart. Pleural cavities, the pleura, you know that they are divided into parietal and visceral pleura. Visceral pleura is that which immediately surrounds the lungs. No part of the lungs is spared of the where the visceral pleura is reflected onto the parietal pleura, right? Hilum lies on the medial aspect of the lungs, which you can see in the diagram. There are two lines are running on the medial aspect, and in the center, these lines are reflected onto each other. So this is the only part of the lung, hilum, where the visceral pleura is not present. Otherwise, all the part of the lung, including the fissures as well, they are covered by the visceral pleura. Parietal pleura, on the contrary, that is present, which is lining the inside of the thoracic cavity. It is intimately in contact with the thoracic cavity, the endothoracic fascia, right? It is not separated from there anytime. And the gap between the visceral and parietal pleura, it is always there, which is filled with the thin film of fluid. And this is we call that pleural cavity. So the pleural cavity is the space between the parietal and visceral pleura. That is the thin space which surrounds the lungs. Lungs are not present within the pleural cavity. Normally, the pleural cavity only contains a thin film of liquid that allows the slipping movements of the lungs while expanding and deflating. So the visceral pleura is attached to the lungs, and the parietal pleura is attached to the cavity. So whenever the thoracic cavity moves, if it expands, it carries with it the parietal pleura, so the negative pressure develops, and the lungs then they suck the air in. And because at no time the visceral and parietal pleura, they separate from each other. They are separate from each other at certain places which are called recesses, costodiaphragmatic recess, like on the other side. When the lungs collapse during expiration, then the thoracic wall, they become in close contact to each other and without any visceral pleura. That is the costodiaphragmatic recess, right, on either side of the lower angles of the thoracic cavity. So this is about the pleural cavities. It is a potential. It is called potential space. Why is it called potential space? Because if there is collapse of the lungs, for example, then what will happen? That the negative pressure which will develop in the pleural cavity, it will suck the fluid, and the fluid will accumulate in the pleural cavity, which is called pleural effusion, right? So in that case, that would become a real cavity. Otherwise, it is not a real cavity. It is a potential cavity which can be filled with fluid under certain circumstances. Here you can see the reflections of the parietal and the visceral pleura. It's a diagrammatic representation of the structures. And what are other structures of the body which lie in the thorax? Mainly you see that in the middle mediastinum, in a fibrous pericardium, lies the heart. Heart itself is innervated by the visceral and parietal pericardium, and the structures which are coming out of the heart, they are the great vessels, the ascending aorta, arch of the aorta, descending aorta. Then the three important vessels are rising from the arch of the aorta. Those are, I told you before, they exit the thoracic inlet, and at the same time, the structures which are entering the superior vena cava, which is receiving the right and left innominate veins, or the brachiocephalic veins, which are coming from the right side and from the left side from the thoracic inlet, and the superior vena cava is formed. Then you can see that the fibrous pericardium, it is resting on the thymus are present in the superior mediastinum ribs, right? And you also have to percuss. Then you can see the upper border of the upper border of the liver over there. You can percuss over there, right? And the lines which are present, imaginary lines, this is the mid-sternal line which is running straight down on the medial side. Then there are parasternal lines which are running alongside the body of the sternum. Then there are mid-clavicular lines which are running between the two ends of the clavicle. There are the mid-clavicular lines. Then anterior axillary fold, the line running from here, that is the anterior axillary line, and posterior axillary line runs from behind. And the mid-axillary posterior medial line is present there, and paravertebral line would be alongside the vertebrae, or the scapular line would be that which is running through the inferior angle of the scapula. So there are different imaginary lines which divide the thoracic region into different planes, and which you can relate to the structures lying inside that area. So that is the you should be able to palpate the anterior fold, posterior axillary fold, and you should be able to palpate the apex bead, which will spend the fourth intercostal space on the left side, 9 centimeter lateral to the sternal angle on the left side. Sorry, mostly. Sometimes it may be on the right side, and this is how the surface anatomy comes into account. Posteriorly, you should be able to palpate the spinous process of C7 vertebrae. This is the most prominent vertebra over there, and just below that, the posterior limit of the thoracic cavity is there. But actually, this region is called the region of back. But you should be able to palpate that, and scapula. You should be able to identify the margins of the scapula. You rotate the scapula, and you should be able to see the different parts of the scapula, because scapular spine can be palpated. Acromial process can be palpated. The most prominent part on the lateral side of the shoulders, that is the acromial process. Then anterior angle of this, inferior angle of the spine, inferior border, they all can be palpated. So this concludes the lecture, today's lecture. So any question from your side is welcome. I'll try my best to answer you.
Thank you, sir. Any students having the question can raise the hand, so I will unmute their mic. And also you can ask a question on the chat, so sir will answer on voice also. Sir, chat is enabled for the students. If the student want to ask question, type in the chat box.
Okay.
Sir, have you seen your chat box in the screen?
Yes.
There's a question from Mohammed
Ashif. Okay, one question is, can you repeat the attachments of Simpson fascia? Simpson fascia is the suprapleural membrane, which is attached on lateral side with the innermost margins of the first rib, right? From front to the behind. And on the medial side of this this is the limit on the lateral aspect of the thoracic inlet, so that the dome of the lung does not extend into the neck. Which book to study? The books to study, I think KLM is a good book, Snell's Anatomy, or whatever book you like, which give you the sense of understanding. And I would stress you, if you want to study anatomy, then you should always keep an atlas in front of you, right? It's not, you cannot understand the structures unless you see the structures. Or if some videos are available on the YouTube, you can view the videos as well. First step, actually the questions are running fast. 1 minute. Can you attachment of similar? I have answered that. Are contents of root of neck and thoracic inlet same? No. Thoracic inlet, some structures in the root of the neck are those which pertain to the neck region only. They do not extend into the thorax. Only the structures which pass from the neck to the thorax, those are the structures which will be called the structure of the thoracic inlet, right? Which book to study? I have answered that. Thoracic inlet contents. Thoracic inlet contents, I told you that the, for example, the trachea, the esophagus, the recurrent laryngeal nerves, the vagus nerve, the phrenic nerve, then the arteries are the right common carotid, right subclavian, because at the just at the inlet, these the right innominate with and on the left side, the two are separate, right common carotid and left common carotid and left subclavian, right? And in addition to that, there is a, I told you that thoracic duct also opens over there, and the recurrent laryngeal nerves, and posteriorly on sides of the vertebrae, the sympathetic chain also enters the thorax through the posterior aspect. Can we palpate first rib easily? It's not easy to palpate first rib because it lies, part of that lies beneath the clavicle. So the easiest way to count the ribs is to palpate, first you palpate the sternomandibular joint, and then on the just lateral to that, the second rib is attached. Thank you, Dr. Zaheer. Welcome. Sir, great job with the lecture. I loved your videos on YouTube. My parents enjoyed them. Thank you very much, Muhammad. Gray's Anatomy. Gray's Anatomy is for students. You can study it for students, not the main Gray's Anatomy. That will take too much time. If you can afford time, then you can certainly consult. That is a reference book, right? Can you please explain the question, pleural cavity is potential space? Now, this is a very important question to understand. Pleural cavity is a potential space. What do you mean by this? Cavity can be when, for example, a balloon, when it is not inflated, it has got a cavity, but it's not, that cavity is not filled with anything. That is a potential cavity, right? When you fill it with the air, then it becomes a real cavity. Similarly, the pleural cavity is the space between the parietal and visceral pleura, and it is not actually existing over there, right? When something is filled in that, for example, air, like pleural effusion, or some fluid is filled over there, then it will give rise to pleural effusion and hemothorax or something like that. Then it will become the real space, right? Very nice lecture. Thank you. And thank you, sir. Any question?
Hello, sir.
Ji.
It's almost ending the time, and I have to join the second session. So can we end up now?
Okay, students. Thank you very much.
Thank
God
you
bless
so
you,
much, sir.
and have a nice stay at home.